Peter, it seems like
Good evening, everyone. Please, we'll be starting at exactly 5 minutes after 4 to give room for others to join the call. Thank you for your patience. Good evening, everyone. Please, can you hear me?
Yes, we can hear.
Yes, we can hear you.
Yes, I can.
My name is Dr. Stanley Okafo, and I have the pleasure of moderating today's session. You're all welcome to this ECG training organized by the Internal Medicine Interest Group of Nigeria. Before we begin, just a quick house rules. Please kindly mute your mic throughout the session. There will be a Q&A session after the presentation. You may want to raise your hands and you'll be granted audience to ask your questions, or you can drop your questions in the chat box. The attendance link will be shared in the chat box too. Also, don't forget to have your writing materials ready, as this session promises to be engaging and insightful. Thank you all, and once again, you're all welcome. Next, I'll be inviting the President, Dr. Harley Okwilagwe, for his opening remark.
Good evening, everyone. I'm pleased to welcome you all to this Imgn Ecg Training program. This is a one-of-a-kind training program, and we aim to, at the end of the program, we aim to be able to give a good briefing of the ECG, and we aim to also help in mastering of ECG. This program is also going to involve this program is also going to have a space for certification, which is going to have various collaborators, including those of our speakers. We're able to also make sure we provide the best of speakers, and we want you to be rest assured that this training exercise is going to be very fruitful. We want you to stay calm and stay ready, stay hopeful, and we promise to give the best. And also, please, as we go through each session, we advise that we open our mind to every training session. After each session, you go back, do your dressing work, make sure it's thick, and answer the follow-up questions. Feel free to ask any questions. Our speakers are ready and they are willing to impact. God bless you as God bless you as you participate in this program, and we'll do our possible best to ensure the best for us. So thank you very much. All.
Thank you, Dr. Harry. Just like he said, this training is going to be eventful, so please get your writing materials ready and take down important points. Up next, I'll be introducing our guest speaker. Okay, it is my honor to introduce a physician and a mentor whose work has touched life both within and beyond our borders. Dr. Bumi Ajala is a consultant cardiologist at the University of Port Harcourt Teaching Hospital. She is a fellow of the National Postgraduate Medical College of Nigeria, the West African College of Physicians, and an ordinary fellow of the Royal College of Physicians, London. Her areas of special interest include heart failure, cardiovascular imaging, and geriatric cardiology. In pursuit of excellence, she also earned a postgraduate diploma in geriatrics from the University of Buckingham. Beyond her impressive qualifications, Dr. Ajala is deeply passionate about research, mentorship, and improving patients' outcomes. Today, we are privileged to hear from a cardiologist whose dedication continues to inspire colleagues and transform lives. Please, let's react with our emojis as we welcome Dr. Bumi Ajala.
Thank you so much for your generous introduction. Good afternoon, everyone. My name, like they have rightly said, is Bumi Ajala. I'm trying to share. Okay, put it on slideshow. All right, so today I have the privilege of starting this ECG training, which is going to span over the next 4 weeks. And I was happy when I saw that, it was broken down into segments, because ECG is not basically something you can learn everything in one day. And even beyond this training, it's important to note that ECG learning ECG comes with constant practice. So it's something that you have to look at an ECG every day, go back, check, and can we please all mute our mics? Thank you. All right, so today I'll be taking the foundations, ECG foundations, and I hope that at the end of this session, I'll be able to impact 1 or 2 things to you guys here today. So the goal of this academic session is to understand the ECG waves and intervals, which I'm sure some of us here already know about, interpretation of ECG as in how you look at the waves and how to make sense of it, then outline the criteria for the most common ECG diagnosis in adults. We won't do too much of that. It's meant to be like just a foundation, and then describe some clinical applications of ECG. So let's just delve into a bit of history of how, we started the whole ECG stuff. So in the 19th century, an Italian scientist, which was named Carlo Mattuzzi, realized that there was an association between electricity and the heartbeat. And several other scientists started doing some work on that. But the major breakthrough was by William Beethoven, who was a Dutch physiologist, and he was regarded as the founder of modern ECG. And he invented the first practical ECG machine and also developed the 3 standard limb leads. I'm sure that for some of us have come across ECG, we know what we've seen or heard of what they call the Beethoven's triangle, which was named after him, and it's labeled according to how the leads are placed. And he also even received medals, Nobel Prize for his work on the ECG. So William Beethoven is the guy who invented ECG, and ECG has come a long way from when it started. So you can imagine that this what the first ECG machine looked like. It weighed about 600 pounds, very large. And then the patient had to immerse his hands into a salt solution, which was transmitted into this big machine to, record the electrical impulses of the heart. So you can see the right arm, the left arm, and the left leg immersed in the salt solution, which now transmits the impulses to the machine. So, but we know what the ECGs have come to today. In fact, they're very portable ECGs, or you can even do an ECG with your smartwatch or your phones. So what's an ECG? What's an ECG? So an ECG is a representation of the electrical events of the cardiac cycle. I'm trying to minimize this, okay? Of the electrical events of the cardiac cycle. And it has very distinctive waveforms, and each of the waveforms obviously throw a great insight into the patient's cardiac pathophysiology. And you can see the diagram below just highlighting some of the waveforms, which are the things we'll be discussing today. And what can your ECG help you identify? Several things. You can identify abnormal heart rhythms like arrhythmias. You can determine if the patient has myocardial ischemia, or if the patient has an infarction or pericarditis just by looking at the ECG. You can determine if your heart is enlarged, if you have chamber hypertrophy, what chambers are even hypertrophied. You're able to tell with the ECG with some bit of sensitivity. And then electrical disturbances can also be reflected on the ECG. Like we know that we look at an ECG of a patient that has hyperkalemia, we're talking about tau tented T waves and some other changes like that. And also drug toxicity. We know that there are a lot of drugs that causes prolongation of the QT interval. There are very long list of drugs, and definitely on the ECG able to denote that. And also the digoxin has some specific ECG changes if you have toxicity. Recent advances that also extended the importance of ECG. So what is being done with ECG now is even different from you. There are some very advanced ECG, we call them signal average ECG, which detects very small fluctuations in the ECG readings and can tell you about things. It can even help diagnose a patient that has an arrhythmogenic right ventricular dysplasia, all big stuff. And then you can actually even predict some diseases that have not even started. Just by looking at the ECG, you can tell the patient that is prone to sudden cardiac death. You can tell the patient who will be prone to developing heart failure, even in the future. With the advent of AI and all this machine learning and deep learning models, you're able to do that. So let's start with the topic for today, and then some basic definitions. When you say this depolarization, what do you mean? It means that the cardiac threshold, which is the threshold potential, has become less negative. That means it's more positive now. So you have a baseline membrane potential of the cells of the cardiac muscles, which is called the resting membrane potential. So and it's typically around 90 thereabout. So if you have that resting membrane potential increase, that's become more positive. And when this happens, it makes the cell more excitable. You have influx of some ions, you have efflux of some ions. So basically, when you have influx of sodium, then you have the depolarization occurring. And the heart muscles needs to depolarize for the process of contraction to occur. So I'm sure we have come across something that looks like this. So this is the cardiac myocyte depolarization graph, and this is what it looks like. The phase 4 here is the resting membrane potential or the threshold potential. And when it becomes more positive, that's when you say depolarization has occurred. And what happens is that you initially have some influx of sodium. You have this one is a transient potassium efflux. Then phase 2, you have influx of calcium, which maintains the plateau phase. And then you now have potassium efflux. That's efflux moving out of the potassium from the cell. And that's what causes the repolarization of the cell. This is not what we're discussing today, but it's just to note. And then the pacemaker depolarization, it's important to also note that the cardiac myocyte, which is a muscle, and then the pacemaker of the heart. The pacemaker of the heart are like the SA node, the AV node, and then those are the ones that trigger pulses. They have a different depolarization graph from the cardiac myocyte, but they still use the same ions. So what are the phases, what are the graphs on the ECG that talks about depolarization, cardiac depolarization? You have the P wave. The P wave is the initial wave here, which starts the ECG graph, and it connotes atrial depolarization. So when if you see a P wave here, then you're talking about atrial depolarization of the atrium, which is what actually starts the phase of the cardiac cycle. So after the P wave is seen, then you have the QRS complex. The QRS complex denotes ventricular depolarization. So when you're looking at the P wave, you know that abnormalities of the P wave should be looking for problems with the atrium. Then what happens with my P wave? If my P wave looks wider or looks taller than it should be, then probably it's taking a longer time to depolarize because the size has increased from what it should be. So P wave denotes atrial depolarization. The QRS complex connotes ventricular depolarization. And the ventricular QRS complex definitely has a certain fixed size. You expect it to not last more than about 0.11, which we'll get to to 0.12 seconds. So if you have a wider QRS complex, imagine that your QRS complex is now wider than what it should be, then it will mean that the QRS, the ventricles, is taking a longer time to depolarize. What can be making the ventricles take a longer time to depolarize? That would mean that probably it's larger or thicker than what it should be. So if you have dilated ventricles, then you expect that it will take a longer time to depolarize and the QRS complex will be wide. So that's for depolarization. So what is repolarization? Repolarization is a phase of recovery. And after the cardiac cycle, depolarization occurs, ventricular contraction occurs, then there should be a rest phase where the potential returns back to threshold, the cardiac muscle returns back to resting before another process of contraction will start. Because imagine that the heart continuously contracts all the time without relaxing, then it will be stressed, it would wear out easily, and then different things would occur. So there should be a resting phase. So the recovery phase is usually a slow process, lasts about 100 milliseconds or longer, and what's on the ECG denotes the ventricular repolarization. That's the phase from the end of the S, because we said QRS complex is for ventricular depolarization. So at the end of the S, and till the end of the T, that STT segment is where we talk about ventricular repolarization. So if you're looking at this ST segment, T wave changes, then we'll be looking at repolarization abnormalities, basically. So what's the pacemaker of the heart? Pacemaker is where the trigger for these electrical impulses comes up, basically. And the whole cardiac muscle has the ability to become pacemaker tissue. But we have a primary pacemaker. The SA node, that's the sinoatrial node, is regarded as the dominant pacemaker or the primary pacemaker of the heart. If you have problems with the SA node, if you have diseases affecting the SA node, then other parts of the heart will pick up and take over the pacemaker function of the heart. So, but since the SA node is the primary pacemaker of the heart, then it's considered that in a normal heart, if the SA node discharges, then your heart rate will be between 60 to 100 beats per minute. But peradventure, the SA node is not working and another part of the heart has to take over. The AV node will be the next, and the rate of the AV node will be discharged at 40 to 60 beats per minute. And it becomes a backup pacemaker. But let's assume that you now have a complete AV nodal block. Nothing is happening. Maybe you have like a complete heart block where the AV node is blocked. Then the ventricular cells takes over the pacemaker function of the heart, and it conducts at a much lower rhythm, and that's the rhythm. It's about 20 to 45 beats per minute. So in the normal conducting system of the heart, like we said, the wave of depolarization starts from the SA node. So if you have the SA node being triggered, then electrical impulses moves through the right atrium, and the SA node is located in the right atrium at the junction of the superior vena cava and then at just above in the right atrium here. So if you have these electrical impulses, it transmits through the right atrium. It transmits with the wave of impulses, moves all through the right atrium. Then you have some of these fibers called the Bachmann bundle. It punctures the intra-atrial septum, goes to the left atrium, also to depolarize the left atrium, also for activities to occur. And then these impulses also conducts to the AV node. And when it gets to the AV node, you have a slight AV nodal delay. And this AV nodal delay is what allows for complete atrial contraction. You know, when the atrium contracts, it contracts and squeezes out the blood within it into the ventricle. So that's AV nodal delay, which is physiologic. It allows for proper ventricular filling so that your cardiac output will, make sense. So that's why you have that physiologic delay. And that physiologic delay is represented on the ECG by the PR interval. So if you now have a prolonged PR interval, you will know that it's taking much longer. This physiologic delay is taking much longer. Probably there's a problem with the AV node, it's diseased or something. And then when you have that transmission of electrical impulses into the AV node, it conducts through the His bundle, which now divides into the left side and the right bundle. So you have the right bundle taking the impulses to all parts of the right ventricle, and then you have the left bundle dividing into an anterior and posterior one, because you know the left side of the heart is bigger anyway. So also depolarizing the whole left ventricle. And so these are the Purkinje fibers. And then, so let's move to the ECG, because we're meant to talk a bit about the electrophysiology, and that's why we spoke about that. So the standard ECG has 12 leads. I'm sure we all know that. We have 6 precordial leads, and we have the 6 limb leads. The precordial leads or the chest leads are the ones that stay on the chest. And we have the limb leads. We have those 3 standard leads, which are lead 1, lead 2, and lead 3. And we have the augmented leads. The augmented leads are lead AVR, AVL, and AVF. The standard limb leads are bipolar. And what does this mean? It detects the potential difference from one lead to another. So lead 1, basically on the ECG, detects the potential difference from the right atrium to the right arm to the left arm. Then lead 2 detects the potential difference from the right arm to the left leg. Lead 3 detects the potential difference from the left arm to the left leg. Those are the lead 1, lead 2, lead 3. So what makes it different from the augmented lead? So we have the augmented leads, which are the AVR, AVL, and AVF. And these augmented leads are the ones that actually helps to determine the axis of the heart. And the augmented leads are unipolar leads, but they are much more, will I say, advanced in that what they do is that they detect it. So AVR detects the electrical difference between the 2 other parts of the 2 other leads here. So AVR detects the potential difference between the left, so this potential difference between the left arm and the left foot. Then the AVL detects potential difference between the right arm and the left foot, while the AVF detects potential difference between it and the right arm and the left arm. So that's what makes the difference. And you see when it's reconstructed, you'll have this graph here, which is what helps us to determine the axis of the heart. So basically, if you want to place our ECG, we know that ECG placement is done on the one for the chest is done at the 4th intercostal space, both on the right and the left. And then on the left side, you place the V4 at the apex of the heart. You place V3 in between V2 and V4. And then on the same side where the apex is, you just continue along that side. You place your V5, anterior axillary line, mid axillary line, and then towards the back, you can continue to place your lead V7 to V9 if you're looking for something there. So that's the placement. And then for the ones on the limbs, you can place them on the shoulder, or you can place them around the wrist. So that's the right arm, left arm, the right leg, and the left leg. So those are the placement of the lead. And then by the time you're done, this placement of the leads, you can see this triangle, which is what Williams-Einthoven also describes. It helps to determine the axis of the heart by a lot of reconstruction I've done. So the AVR, basically it's minus 150, AVL minus 30, AVF at 90, and then by the time you reconstruct the standard limb leads, you have the lead 1 here, lead 2, and lead 3. This is just something that you need to know. You don't, the explanation will come later, but you have to, if it's necessary anyway, if you feel, well, the basic things to know is just the simple ones. So we've talked about this already, about the standard limb leads, and then the placement of the chest leads, which are V1, V2, V3 to V6. We've also talked about it, and these are the locations where they should ideally be. And then the precordial leads, what do they represent? V1, V2 is looking at the septal area of the heart. V2, V3, V4, anterior, and V5, V6, lateral. So if I had maybe like a T-wave inversion or in V1, V2, then I'll be thinking of probably like a septal myocardial ischemia. If I had V1 to V, I can say an septal or say an extensive posterior caudal ischemia. So basically, I just put this normal ECG here. You can see for everybody here, I'm sure we have seen an ECG before. Can the person have his mic muted, please? So okay, so this is a normal ECG, and you can see all the leads that we described. V1, V2, V3 are limb leads. These are the standard limb leads. AVR, AVL, AVF are augmented leads, and from V1 to V6 are chest leads. So when you look at an ECG paper, you have tiny boxes within a bigger box. Each of the small box measures 0.04 seconds or 40 milliseconds, and a large box is 0.2 seconds or 200 milliseconds, whichever one suits you better. So, and then vertically, a large box, it's about 5 millimeter or 0.5 millivolts. This would be necessary as we go along. So if you look at a normal ECG paper now, the first thing to look at is to look at this. There's usually this telling you the frequency of the ECG that you're looking at. So if I looked at this, and this is covering two big boxes in terms of the vertical aspect, then I would know that the calibration of this ECG is normal. I don't have to divide, I don't have to add. This is very important because sometimes you look at an ECG, you say, oh, there's no LVH. However, they have halved this millivolts here, and it's maybe 5 millimeter. Probably the amplitude of the ECG was so high, and some machines are automatic. They do it automatically. They just half it so that all the amplitude fits into that ECG paper. So this is what you have to look at first. If you find 2510, then that's the normal amplitude of a normal ECG, and you don't have to multiply or divide whatever you get. And in interpreting the ECG, it's important to know that the accurate analysis of ECG requires thoroughness and care. And then you can't report an ECG in isolation. You have to report an ECG in whatever, determining with the patient's age, gender, and clinical status, because we know that some of our, let's say, criteria will talk about this for women, that for men, and then even for females, the ECG QT interval has a longer QT value than that for males. So you have to always look at that when you're analyzing your ECG. And so because just to avert mistakes, because if you do not do that, then you might be omitting some important things that you're meant to read. So, okay, don't know why I cannot move my slides again. Sorry, trying to move the slide. Oh. No. Okay, all right. All right, so we've talked about this, the normal ECG waves and interval. We have the P wave, we have the QRS complex, we have the ST segment, the T wave, the U wave, and the QT interval. And those are all the things we're going to be looking at systematically. So these are some very important things you should look at when you're reporting your ECG. The first thing is standardization or calibration, which is what I talked about. You look at the calibration of the ECG. Is it 2510? Has it been halved to 25.5? Is it 25/20, meaning that it was too small and then the ECG had to increase the amplitude? So all those you have to look at so that you know that you're dealing with the correct calibration. And then you run through all of these other things, your reading, your heart rate, axis, PR interval, through to your precorder airway prevention. So standardization, I hope you understand what I talked about, the standardization, to look for whether it's properly standardized, 10 millimeters for the vertical mark and then 25 for the width. So this is what I was talking about. This is the normal amplitude where you have two big boxes occupying. So if you look at this, you know that, oh, this is the normal amplitude. If you find this, then any vertical amplitude that you get from the ECG has to be multiplied by 2. If you find this, then anything that you get, rarely would you find it, but if you do, then you have to divide it by 2. And then the reading. How do you determine that an ECG reading is normal? So you look at the bottom strip, which is called the reading. Every ECG, if it's well done, should have what we call a reading strip. And this is the reading strip here. Should have a reading strip. So this is the reading strip here. The last one here is usually they'll use lead 2 or V1 for the reading strip. Some machines will use V5. It doesn't matter. But what you want to look at is that we want to have a longer length of wave instead of just looking at 3 beats. You can see that this is longer, and this records for the whole 10 seconds, because a normal ECG paper would record for 10 seconds. So this records for the whole 10 seconds of the. So what constitutes a normal reading? First, is there a P wave before each QRS complex? This is a P wave. This is a QRS complex. So if you have a P wave preceding every QRS complex, then hello? Okay. So if you have a P wave preceding every QRS complex, then that's one of the factors that tells you that it's a sinus. What's happening that I'm being muted? The co-host is muting me. So then another thing is that when you have your PP interval, that's an interval from P here to another P, or your RR interval, one interval from R here to another R. If it's regular, you're looking at all this reading strip, and you can see that your PP interval or your RR interval is regular. That also tells you that you might be dealing with a sinus reading. If you're in doubt about the regularity, just put a white paper under this P and the R, and then use your white pen to dot where each of the R or each of the P's are. And then you'll be able to detect, just looking at the paper after you've done that, you're able to look at it and say, oh yeah, this thing looks regular. Just if you're unsure, but most times you can determine that just without doing that. But sometimes you're not very sure. So P wave before each QRS complex, PP interval or RR interval is regular. If your rate is between 60 to 100, that's another one. And then if you have your P wave being upright in lead 2, so these are the things that are written here. So if there's a P wave before every QRS complex, that's one of it. If are the PP or the RR intervals regular, that's another one. If you have an upright P wave in lead 2, that means the P wave is likely coming from the impulse is likely coming from the sinus node, not another part of the atrium. And then if the rate is between 60 to 100. So let's even imagine that you have these first 3 and the rate is not between 60 to 100. It's still a sinus reading, just that it will now either be a sinus tachycardia if the rate were above 100, or it'll be a sinus bradycardia if the rate were below 60. So that's for sinus reading. Then how do you determine your heart rate using the ECG? You have the rules of 300 or 15, or use the 10-second rule, whichever one it is. Well, most times you can use the 10-second rule for everyone, but you would not be able to use the 10-second rule, the 300 to 15, if your reading were to be irregular. So how do you use the 300 to 15? You want to count the number of big boxes between your QRS complexes and divide by 300, or you count the number of small boxes and divide by 15. So let's use this as an example. So I have these big boxes here, 1, 2, 3, 4, 5. If I add this one to it, it's about 6. So if I put 300 over 6, I'll get 50 beats per minute. So by reading here, my rate here is 50 beats per minute. And so if I were to report it, I'll say probably I have a sinus bradycardia, because yeah, it's looking regular. My P wave is before each QRS complex, and then the RR interval or even the PP interval is equal. So that's one way of determining the heart rate. So let's look at another example. So looking at
Good evening, ma. If I a bit fast.
I'm fast. Okay. All right.
Yes,
Sorry.
thank you, ma.
It's okay. So So looking at this one, so we're trying to determine the ECG rates now. And we have these big boxes, and you know that inside these big boxes, we have tiny, tiny, tiny small boxes also. So if we're using the big boxes, let's assume that we have perfect big boxes and we're using the big boxes. So I will count the big boxes now. 1, 2, 3, 4, 5. I have 5 already, but then I have these ones that are cut. If I count this one, it's about 4 here. And on this side is also about 1. So if I put this one together with this, it's almost another big box, right? So that would make it 6 big boxes, let's assume. So 300 over 6 gives me a rate of 50 beats per minute. But using this same thing, let me assume that I now want to use the small boxes. I have 1, 2, 3, 4, 5. And inside one big box, you have 5 small boxes. So having these 5 is already 5 times 5. I have 25, right? Then I'll count the remaining. I'll say 1 here. There's about another one on this side. So 25, 26, 27. Then I come here, 28, 29, 30. If I wanted to drag it a bit, I'll say 31. So if I do 1/5 divided by 31, I'll be getting something close to, I'll also be getting something close to the 50. I'm trying to use my calculator. So if I do 1/5 divided by 31, I'll be getting about 48 beats per minute, which is almost close to 50. That's if I wanted to get it accurately. But if I'm using the big box, that's what I'll do. So let's try with this one also. So if we're to determine the heart rate using this strip that is in front of us, how many big boxes do I have? I have 1 big box, 2, 3 big boxes, right? I don't have a complete big box. The next thing that I have will be about, so if I wanted to approximate it, because I have 3 big boxes and then the other one is about 2 on this side, 2 on this side, which is 4. So if I want to say, oh, I have 4 big boxes, then I'll say approximately 75. But we all know that the boxes here, they're not exactly 4 big boxes. So let's use the smaller boxes to determine. So 1 box here is 5, another box here is 5, 10, another box here is 5, 15, then plus 4 boxes here, 19. So if I was using my 1/5 instead of the 300, I'd say 1/5 divided by 19, which is the number of small boxes we have. And then it will give me a rate of about 79 beats per minute. That is in using the big, so we have used both the big box and the small box to determine the heart rate of this strip. And what we're looking at are the boxes in between the QRS complexes. So the boxes in between this R, so we call this an R and an R. So the boxes between these RR intervals is what we're using. So let's look at another one. This is an abnormal reading, definitely. Just looking at this is a reading that looks like a ventricular tachycardia. It just looks like a primary school child writing some jaga jaga, but this is a ventricular tachycardia. So let's imagine that I want to determine my rate using this type of reading. Each of these are the R, each of these are the QRS complex. This is one, this is another one, this is another one, this is another one. So definitely, if I'm looking at my RR interval, I'll either be looking at the topmost part here to this point, or I want to look it from below, here to this point, whichever one you choose. So let's look at all the small boxes that is in between here. I'd say 1, 2, 3, 4, 5, 6, 7, 8. So I have 8, 1/5 divided by 8. So if I do 1/5 divided by 8, I'm going to get about 188 beats per minute. So that's kind of like the rate for this ventricular tachycardia, which is definitely a fast one. So that's using the big box and the small boxes to determine your rate. But you're mostly able to do that when you have a regular reading. That's when your RR intervals are equal. So imagine that you didn't have equal RR interval. One is appearing closer to it, another one is far from it. You won't know which one to pick because the RR intervals are not equal. That's where you come to using the 10 seconds rule. So the ECG strip reads for 10 seconds. And this last strip that we have here, which I've talked about, is a reading strip. That is, most ECG should have a reading strip. Sometimes some people report some ECGs and you can't find the reading strip. That's not right. So this is the reading strip. So if I want to use the 10 seconds rule, I will come down to this reading strip and I will look at all the hours that I have here. So I put this arrow there so that it makes it easier for us to count. So if we're counting together, I will say this is 1 hour here. So this is 1, this 2, this 3, this 4, this 5, this 6, this is 7, 8, 9, 10, and 11. So I have 11 hours in the period of 10 seconds. And you know your heart rate that you're trying to determine is your heart rate in what? 60 seconds, right? It's how many times your heart beats in 60 seconds. So if I already have this number of hours in 10 seconds, if I want to make it up to 60 seconds, what do? I multiply by 6. So I will now take this number of hours that I have, which is 11, and multiply by 6. If I multiply it by 6, I'll get 66. And so using the 10 seconds rule, my heart rate for this ECG is 66 beats per minute, because I have just used the reading strip, counted the number of hours there, and multiplied it by 6 to give me the heart rate in 60 seconds. And if we were to now use, I put this there so that we'll now look at it. So look at the down one here. In fact, there are 3 reading strips here. There's V1, 2, and V5. I told you that any of those strips can be used as the reading strip. So if you look at this ECG, the last 3 are all reading strips. So if anybody could calculate for me what the heart rate will be using this reading strip, I'd be happy to get a figure. I'd give 1 minute and then would like to get an answer so that I know that I'm talking to people actually.
90.
90, yes, that's great. That's perfect. At least I'm happy that we understand. So we have about, I think, for those that don't understand how we got 90, they counted the number of hours here, which is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 15 are multiplied by 6, which gave us 90. And like I told you, if you look at this ECG, you see that the intervals are not regular. Some are small. So this one is wide. This one is also wide. You know, you have another small one. So you are not just going to pick any one and say, this is the one I want to use, and I want to use the big boxes. So that's where it's important that you use the 10 seconds rule. So this is also definitely an abnormal reading, and you can see it's irregular. It looks like a polymorphic ventricular tachycardia. So if I had to calculate the rate here too, this is the same thing I'll use. Calculate all the hours that I have here. You can see this dot on top to identify each of the RR intervals, and then multiply it by 6, and it gave a rate of 198 beats per minute. Very easy, right? Yes, it is. So now we move to the axis. So the normal axis of the, I'm sure most of us have seen this before. The normal axis of the heart is minus 30 to plus 90. That's from here to here. And then anything between minus 30 to 90, you say you have a left axis deviation. Anything between 90 to 180, right axis deviation. And anything between minus 90 to plus 180 here, indeterminate axis. Nobody will ask you for what's the minus whatever and all of that. So, but for those that are coming to cardiology, you can decide to know this. And then how do you determine your QRS axis? There's always an easy way that we teach students and residents. And then for those going to cardiology, or maybe you might want to now say, okay, tell me the exact degrees and all of that. So the QRS axis, it represents the overall direction of the heart's electrical activity. So when they say you have like a left axis deviation, what is happening? The left axis deviation, it might be that you have left ventricular hypertrophy. So the overall direction of the heart's electrical activity is more towards the left, and that's why you might have like a left axis deviation. Or imagine that you have a pulmonary embolism and the right side of the heart is dilated, is big, and you know, undergoing some strain. Then the overall direction of the heart's electrical activity might be tilting towards the right. And when you look at your ECG, you might have a right axis deviation. So it gives hints about ventricular enlargement and also conduction blocks. So basically, how do you determine your axis? You have the quadrant approach and you have the equiphasic approach also. So what, sorry, and you also have the equiphasic approach. So just looking at this, I want to also identify that if you have any ECG graph looking like this, then this is more like a predominantly positive electrical impulse. Then if you have, it's more towards the lower part, then you say it's a predominantly negative. And then sometimes you have a biphasic or equiphasic impulse where the top and the bottom are equal. And then you see that most of this you'll see for the normal left-sided leads, and then for right-sided leads like AVR, V1, V2, they're usually predominantly negative. And so using the quadrant approach, if I want to determine my axis, we look at two leads. We look at lead one, and AVF. So if my lead one is predominantly positive, meaning that it's more of an R wave, the one going up, and then my lead AVF is also predominantly positive, I'll use an ECG to look at that. Okay, sorry. So if lead one is predominantly positive, AVF, let me just move to, okay, what an ECG looks like. Okay, this is not the normal one. Okay, so look at this one now. Oh, why am I don't want that. Just let me get to a normal ECG. Okay, so look at lead one here. Lead one is predominantly positive, meaning that you have a positive deflection here. And lead AVF is also predominantly positive. Then here you can say what you have is a normal axis. However, if you have lead one being predominantly positive and the AVF is predominantly negative, not that you don't have anything on top. Sometimes you have a small deflection on top, but then it's more negative than positive. There you say you have a left axis deviation. Sometimes you'll say if lead one is positive, lead AVF is negative, then the person is not sitting right because the legs are wide open and that is left. It cannot be right. That's some silly way of looking at it. And then, so, but if you have lead one being predominantly negative and then AVF predominantly positive, you can see negative, positive, they're kind of going to join and close together. Then that's a right axis deviation. However, if you have lead one negative, AVF negative, that's an indeterminate axis. So it can be an extreme right or an extreme left, whichever one. So let's look at what we're talking about the axis now. So looking at some ECGs here. Someone can look at this ECG for, okay, the answer is already there. So you can see that the lead one here is what? Predominantly what? Can I get an answer? Lead one here is predominantly
Negative.
Predominantly negative. And then the AVF is predominantly what?
Positive.
So here you can see that this is a right axis deviation using the quadrant approach. Then if you have to look at this one example now, so lead one is predominantly
Positive.
and then the AVF is predominantly negative. So this is what this is, left axis deviation. Easy peasy. So now that's for the axis. However, you have the equiphasic, if you want to look at the other approach, which is the equiphasic approach, I'll just show you that most people don't use it. So if I look at this ECG now, which one is most equiphasic out of all these leads? That has the up one or the down one almost looking.
AVR.
Look at it again.
AVR.
Lead two. I think I agree with lead two. Sometimes even this AVR is actually looking, I think more of the AVR, don't we think?
It's not obvious, man.
Yeah, AVR.
So
Yes,
what
the AVR
explain it again. So the epiphasic one is that the top deflection and the bottom deflection, they're almost looking like they're equal, they're equal in the size. So if we looked at this one, because if I want to compare it with the two, these two, the down one, either 2 or AVR, but I think the AVR, we wanted to count the number of boxes here. I say 1, 2, 3, 4, and then the lower one is about 1, 2, 3, 4. So I think for us here, our AVR is more equiphasic out of these 6 limb leads. Sometimes it can be confusing. Most times nobody uses this. So if I want to get my axis using the equiphasic approach, I now know that my AVR is the most equiphasic. Now, what you're meant to get is you get your angle from the most equiphasic one, 90 degrees to the AVR. So what is 90 degrees to this place? 90 degrees to this place is either here or here, right? Yeah. So if I had to draw 90 degrees from this, my AVR, my 90 degrees will fall on either this right axis deviation side or fall under this left axis deviation side. How do I know which one to choose? How to know which one to choose is that I've already done my 1 and AVF, and it's telling me it's tilting more towards the right. So I'm not going to go to an infinite Isma.
Continue, man.
So that's about the axis. I hope we understood a bit of that. So let's look at this one. If I had to look at this one and I want to use the equiphasic approach, I would look at all of this one. Which one appears most equiphasic out of all of this? I'd say lead 2. Yeah, that's
two.
so if I take my lead 2 and looking at the 1 and AVF already, right? I know that lead 1 is predominantly positive, lead AVF is predominantly negative. So I'm looking more towards the left axis deviation. And then I know that my most equiphasic one is now lead 2. I'd go back to this triangle, which I said we must all know, and put this my lead 2. This is my lead 2 here, which appears 90 degrees to the lead 2 that I have here. It's either going to be on this side, right, on this side. But my 1 and AVF has told me that I'm looking more towards the left-hand side. So I am not going to go towards the right. So if I had to plot my lead 2 against my whatever, then my axis here is going to be minus 30 degrees if I needed to get an exact figure to it. My axis here is going to be minus 30 degrees. If lead AVF was the most biphasic and I was taking 90 degrees to it, then my axis here is going to be maybe like 0. Or if it had told me it was a right axis deviation before, then I'll be looking towards 180. Most people don't look at this, but just for those that are interested in being distinction ECG, then let's look at the intervals on the ECG now. So the interval, like I said, is we have the beginning of the P wave to the beginning of the QRS complex is what is referred to as the PR interval, the beginning of the P wave and the beginning of the QRS complex. We have already said P wave denotes atrial depolarization, and then the PR interval generally tells us about that delay at the AV junction, which is a physiological delay that occurs and allows for proper ventricular filling. It allows the atrium to contract properly and fill the ventricles. So that's your PR interval. So what can happen to your PR interval? Your PR interval can be prolonged. Your PR interval can be short. If you have a prolonged interval, then you say you have what? A first degree AV block. So let's just assume that your PR interval is longer than what it should be. Normal PR interval measures 0.12. That is, it should be about 3 boxes, small boxes to 5 small boxes. That's a whole big box. So any PR interval that passes 3 small boxes to 5 small boxes is regarded as a prolonged PR interval. And when you have a prolonged PR interval, you say you have a first degree AV block. So this is what it is. From the beginning of the P wave to the beginning of the QRS complex is your PR interval. Normal should be 3 to 5 small squares. If it's short PR interval is seen in conditions like Wolff-Parkinson-White syndrome. And then long PR interval, first degree AV block, like I rightly said. So let's look at this. You can see the PR interval here. Let's count it. This from the beginning of this P to the beginning of this QRS complex. I have 2 boxes here, 1, 2, then I have 5 here. So if I had to look at this, one big box is 200 milliseconds. An extra small box is 40, so that's 240. Another extra small box is another 40. So this PR interval is 280 milliseconds, and then you can make your diagnosis of a first degree AV block. If I had to look at the one down here, let's calculate the one down here together. So these, I have 5 small boxes here already, which is 200. Then I add 1, 2, 3, let's say about 4. That's another 4, which is, so who wants to tell me the PR interval here?
260 milliseconds.
160 plus 100. That's 300. Yeah, 360 milliseconds, which is very prolonged, and obviously the first degree AV block is significant. So that's for the PR interval. Then for the short PR interval, it's 3 small boxes. So look at this one with me, lead 1, and see that's P. The P is even small. And then from the beginning of the P here to the beginning of the QRS complex, it's just about 2 boxes, which is 80 milliseconds, and that's not up to 120. So this is a short PR interval, and it's commonly seen in conditions like Wolff-Parkinson-White syndrome, because you can see the slurring of the QRS complex, although let's complicate matters here. So then we have the QRS interval. The duration of the QRS interval should be between 2 to 3 small boxes, basically 2 to 3 small boxes. So the QRS interval, like I said, if you have intrinsic impairment of conduction, either the right or the left bundle, if ventricular conduction is like taking a longer time, like I explained, then you expect a wider QRS duration if you have the ventricular conduction taking a longer time. And what can cause it to take a longer time? If you have a dilatation of the chamber, if you have marked hypertrophy, if you have conduction blocks where the blocks, where the interval, the impulses are meant to transmit, if there's a block, then it's going to take a much longer time for conduction to occur. And then you have the QRS complex being much longer than 2 to 3 small boxes. So you can see this is what we're talking about here. So if you have a conduction in the bundle branches and Purkinje fibers, as seen on the ECG, this is the AV node, which I showed us earlier. And then we have the His bundle here, which divides into the right bundle and then the left bundle. So imagine that you have a block here at the right bundle. Then you say you have a right bundle branch block. And then this will now make the QRS interval that in the leads that shows the right side to be much more prolonged than what it's normally meant to be. So which I'll show you some pictures. So this is a normal QRS complex in V1. This is a normal QRS complex in V6. If you have a right bundle branch block, then you will have a much wider QRS complex. And they call this like a rabbit ear appearance. You have what we call an RSR pattern, which you have something like, looks like an M pattern in lead V1. But in the lead V6, you'll have it looking like a W pattern, not a complete W, but something like this. And then for the left bundle branch block, you can see that This one is much wider. You can see a very wide QRS complex in V1. Why do you have a negative deflection in V1? Because V1 and V2 majorly looks at the right side of the heart. And all the electrical impulses on your ECG mostly represents the impulses of the left ventricle. So even this negative deflection you're seeing in V1 connotes what's happening in the left ventricle. And that's why when you're calculating your left ventricular hypertrophy, that's Sokolow-Lyons criteria that almost all of us talk about. You say S in V1 plus R in V5 or V6, because that electrical impulses is looking at the left ventricle. Once you start to see a positive wave in V1, because mostly what you see in V1 is a negative deflection. Once you start to see a high positive wave in V1, then you can easily tell that even the right ventricle has gathered momentum, probably is bigger, is dilated and all of that, and he's also showing his own power on the ECG, probably even larger than the left ventricle. Then if you see an M pattern in leads V6, V5 and V6, also tells you that you might be dealing with a right bundle branch block. So this is a normal ECG now. So for a right bundle branch block, you either have this RSR pattern, which is the rabbit ear, or you just have like a complete M pattern. But the small R is usually bigger than the big R. So if you have it like this, you can see that the QRS complex, if you had to calculate the number of boxes that the QRS complex is occupying, is about 3. It's about 3 or a little more than 3. And that tells you that you have a kind of conduction, a block or a prolonged conduction time occurring. So these are patterns that you can see for your right bundle branch block. You can see your RSR pattern here and your M pattern there. And then this is another ECG showing us a right bundle branch block. So you can see the M pattern in V2 and V1. So for your right bundle branch block, we are basically looking at your lead. For your right bundle branch block, you are basically looking at your leads V1, V2, and AVR. Those are the right-sided leads that you'll be checking for your right bundle branch block. And if you were just to look at this ECG, just to complete what we're looking at, you can say the axis here is what? One is predominantly positive, AVS predominantly negative. So you have a left axis deviation here and a right bundle branch block, which is a bifascicular block, but don't let me confuse us. Then for the left bundle branch block, how do you look at your ECG and say there's a left bundle branch block? You look at your lead V1 and you look at your V1, V2, and you look at your V5, V6, 1 and AVL. So if you have a deep S wave, you can see this S wave in V1 and V2. If they're very deep and very long and all of that, then it gives you an idea that, oh, we might have a right bundle branch block. But not only that, if you look at the leads that looks at the left parts of the heart. So our leads on this ECG, let me just briefly go to that. Different leads look at different parts of the heart. So and this we should write and just cram. So leads 1, leads AVL, V5 and V6 looks at the lateral part of the heart. Lateral part of the heart. Lead 2, lead 3, and AVF looks at the inferior part of the heart. Leads V1, V2, septal, V3, V4, anterior, that way. So if I had a problem, I'm looking at lead 1 and I see an abnormality, by default, I must look at AVL, V5, and V6 because those leads are looking at the same parts of the heart. If I had a problem, maybe like a T-wave inversion in lead 2, then I must look at lead 3 and AVF to see if the same thing is going on there because they look at the same part of the heart. And same with V1, V2, and V3 and V4. So if I look at this ECG down here and I look at the lead 1, yeah, the QRS complex looks wide. I look at lead AVL. The QRS complex in AVL also looks wide. I must go and look at lead V5 and V6. And then you see that I have this M pattern in lead V5 with the wide QRS complex and almost something similar in V6. Sometimes you don't have a complete M so that you will not be looking at, I have to see this M pattern to say it's a left bundle branch block. Sometimes it might just be a small indentation in the QRS complex. Sometimes it can look like what you have seen in V5. Sometimes it might just be a small, tiny dent, not even up to the one that you saw in B6. And then it can also look like this, but all these patterns denotes a left bundle branch block. But what now makes you tell that it's a complete or incomplete left bundle branch block is the QRS duration that determines that. So if I have this indentation occurring, I have this M pattern, and my QRS duration is still less than 0.12 seconds, that's 3 small boxes, then I am still dealing with an incomplete left bundle branch block. However, if my QRS duration, like what we have here, is much wider than 3 boxes, this is 1, 2, 3, almost starting from here, it's almost like 4, then I can confidently say I have a complete left bundle branch block. So this is also an ECG showing a left bundle branch block. You can see that the M pattern is more apparent in AVL, and then you have the one not looking too fantastic. You can see the small indentation in V5 and then V6 also. So that is, so then we have the QT interval. We'll move towards the QT interval. What is a QT interval? It's the complete time that it takes for ventricular depolarization and repolarization to occur. Since we know the QRS, it represents QRS, ventricular depolarization, and then the ST segment and the T wave represents ventricular repolarization. So the whole QT interval is a period that it takes for ventricular depolarization and repolarization to occur. And it has a normal value. And the QT interval is very affected by your heart rate. So, and that's why when you see the QT interval, you see 2 figures. You see the normal QT and you see the one with a QTC, which means corrected QT interval. So when you have your QT interval, it's always important that you correct that QT interval with your heart rate. There are formulas that can be used to do this, but trust me, you do not need to cram any of this formula to calculate the QT interval. Why? Because there are a lot of apps that you download, all these medical calculators. Once you just put your QT interval, it calculates it and gives you your figure. Life has been made easy, but generally the formula that's used to calculate your corrected QT interval is the Bazes formula, which was developed many, many years ago. But the Bazes formula is not without its own shortcomings and all of that. And so some other formulas have been shown to be better, but seriously, no need to cram this. Get your phone, do corrected QT, and it gives you a figure. So what are the things that can cause you to have a prolonged QT interval? Your QT interval can prolong during sleep and when you have electrolyte derangements like hypocalcemia, hypokalemia, hypomagnesemia. In patients that have myocardial infarction, it can cause a prolonged. Obviously, you can see that the walls of the heart is injured, you have infarction, you have ischemia, so it will take a longer time for ventricular depolarization and repolarization to occur. So the interval will prolong. Then also some drugs can also prolong the QT interval. Sorry, 1 minute. I would need to just. All right. So some drugs and some other conditions can also cause your QT interval to be prolonged. Is this thing not moving? Okay. So then when you also have, then you can have, acquired causes of prolonged QT interval and also congenital causes. These are some of the congenital causes, the Lange, Nelson syndrome, Romano-Ward syndrome. And when you have things like complete AV block or high degree AV block, then the QT interval definitely is likely to also be prolonged. Then these are some of the things that can cause a shortened QT interval: hypercalcemia, vagal stimulation, digitalis effect, and others. So this about the P, we've talked about the P wave, we've talked about the PR interval, we've talked about the QRS complex, and we know what all these waves represent now. So let's take the waves one by one. So the P wave, like we said, represents what's atrial depolarization. The P wave, like I said, is always positive in lead 1 and 2. And that's why when you want to determine whether you have a sinus rhythm, then you'll be talking about a positive P wave in lead 2, which tells you that it's coming from the SA node. So always positive in lead 1 and 2, always negative in lead AVR, and then it's also biphasic in V1, commonly biphasic in lead V1 most times. It can be normal, it can just be positive, but commonly biphasic. And what's the size of the P wave? The P wave typically should not be more than 3 small squares. That's 0.12 seconds. 3 small squares. Any P wave that is now above 3 small squares in width, that means in the horizontal axis, or 3 small squares in the vertical axis, it's abnormal. And this abnormality represents what? So this is the normal P wave. You can see that one part of it represents a right atrium, another part represents the left atrium. So if I have my P wave wider than 3 boxes, which when is wider, sometimes it has this M pattern, not always, you have to note, but sometimes it has this M pattern, then you can say you have a left atrial abnormality. But if you have the P wave being higher in the vertical axis, more than 3 small boxes, then you say you have a right atrial abnormality, either a right atrial abnormality or a right atrial enlargement, whichever one you want to call it. So, and in V1, like I said, the V1, the P wave can be biphasic. You can see biphasic meaning that it has a positive deflection and it has a negative deflection. If you see this in V1, that's actually how some of the P waves a lot of times will look in V1. But if you now have it looking like this, meaning that the one with the negative deflection is much deeper and is more than one small box, then you say you have a left atrial. It even buffers what you see. If you already had like a wide P wave in your lead 2, and then you go to V1 and you see something like this, you see that yes, the one on top is just about a small box, but the lower one is kind of very deep, deeper than a small box. Then it tells you, yes, there's a left atrial abnormality. And same thing with the right side. So let's look at this ECG now and look at lead 2, because lead 2 is where normally, because of the leads and how it looks, lead 2 looks at the potential difference between right arm and the left foot, which is how the heart is actually pointed. So what you definitely have in that axis is a positive deflection. So if I look at lead 2 and I'm trying to look at my P wave here, what do I think this P wave is? Who can try?
P pulmonale.
P pulmonale, which means for
atrial
like us, exactly. So meaning that it's even here. So meaning that you have a tall P wave, which is more than 2.5 small boxes, or the most 3, and then it represents that you might have a right atrial enlargement. So if I come and look at V1, you can see that the P wave in V1 is also biphasic, but the one on top looks like it's higher than one small box. more than the one in the whatever. So it kind of buffers what we're saying here. Then this also this is the same ECG. You can see that the P wave here is tall, it's almost about 3 or 4 boxes. So you have the P wave high in the vertical axis, especially in lead 2, which is where it's more prominent. And then if I come to my lead V1, then I can see that the positive deflection here is actually quite higher than one small box. And this tells me that what I'm seeing here is actually the right atrial enlargement. Then if I had to look for my left atrial enlargement, still that same P wave, it's just that now it's going to be wider. You can see these boxes here, it's clear. 1, 2, 3, so that's 3 small boxes. So the P wave is definitely more than 2.5 small boxes. It has a small indentation that makes it look like an M shape. And then if I now look at the one in lead V1, this lead V1 now, the top most one here, the one on top represents the right atrium. The one below represents the left. So you can see that the one that is representing the left here is much deeper. And it's deeper than, because this is the isoelectric line, it's much deeper than 1 millimeter. So this tells you that, yes, there's really a left atrial enlargement. And then this is a normal ECG showing what we've just talked about. So aside having this M pattern, which tells us that this is left atrial enlargement, if you look at this ECG, there's something also apparent from what we have learned before. There's a first degree AV block, because if I look at the PR interval from here to here, then it will be almost about 8 small boxes, which is 8 times 40. That's 320. So there's also a first degree AV block in this ECG. Then looking at this one, you can see the bifid P wave here. The negative deflection is much deeper and bigger than one small box compared to the positive deflection, which also tells you that, yes, it's likely A. So this is just what I was explaining into better context. You can see the M pattern, you can see the bifid one with the negative component being much deeper, wider. So basically, those are the P waves and what they tell you. P wave tells you about left atrial enlargement, right atrial enlargement. Why would the P wave be higher or be wider? Definitely, if the atrium is bigger, then it's going to take a longer time for the atrium to depolarize. So just normally you expect that you have a wider P wave or a higher P wave because of an enlargement. QRS complexes, you can have different shapes. And that's why I put all of this here. You can have a regular QRS, you can have just an RS, you can have an RSR, which is seen in like a right bundle branch block. You can have a small R and an S, which is normally what you'll find in leads V1 and V2. You can have a QS pattern, which maybe can be seen in infarction, and then QR, different things. But you can see different ones to different leads. You don't need to cram that. It's just trying to tell you that the QRS complexes are not always the same shape. So in lead V1, you normally will have what? An RS pattern, a small R and an S, because lead V1 and V2, mostly what you have is a negative deflection because they are right-sided leads, and the electrical impulses you see on the ECG are mostly the ones transmitting on the left side, because the left side is bigger, so it overshadows what's happening on the right. And then the V6, you can see you have here a QRS pattern. That's Q, but this is just a QR, no S here. So, but you can have a small Q, big R, and an S pattern. So that's the normal QRS complex. So this small R that you have here, it connotes the septal depolarization. And then this small Q here also, it talks about the septal depolarization. And then, so what are the QRS complex? QRS patterns in the precordial leads follows an orderly progression from right to left. So in V1 and V2, like I've told you, what you see is an S wave because it tells you about the left ventricular free wall activation. And then as it progresses, you are going to the left, and then the waves become more positive than negative. And then you expect that by the time it gets to V6, that the S wave becomes much smaller or is totally lost. And that's what we talk about R wave progression. We'll talk about it. So this is, so the normal R wave progression is when you look at V1, you know what you have here is a predominant S, right? When you come to V2, you have predominant S2. But at this stage, you start to have a transition, and that's what's called the transition zone. You now start to have more the R wave becoming bigger, and then you can see that by V4, it has completely transitioned. So the normal transition zone should be about around V3. So sometimes you can say you have an early transition or a late transition. An early transition would mean that you already start to have a prominent R by V2. So you say that's an early transition. Late transition in that maybe even as at V4 or V5, you're still seeing a large S wave. That's a late transition, and you call that a clockwise rotation of the heart. If you have an early transition, you say it's a counterclockwise rotation of the heart. Some ECGs, that might just be what you'll find, and you report it. Sometimes what can cause this late transition or R wave progression, it can be you have an infarction, an ischemia, or a diseased heart. So basically, this is what I'm talking about. You have V1, QS, sorry. By V2, if you have the transition occurring here, you can see you already have a big R in V2. So this is an early transition because this is the transition zone where you begin to already see your predominant R. And then late transition, you can see that here you're still having more of Q and S, more of Q and S. The S is still very marked here until you now get something that is more biphasic around V5. So this is a much later transition. And then this is what we call a poor R wave progression. If you look at this ECG and then you find it being reported, it might be reported as a poor R wave progression because the transition is late, or you find somebody writing clockwise rotation of the heart, something like that. And then we'll talk about the Q waves now. So you can have Q waves normally in some leads, and it's not pathological. So normally you find Q waves in leads like leads 1, 3, AVL, V5, V6. And I told you it denotes a septal depolarization, but it's normally found there. But these Q waves, they will just be small. They will not be wide, and they will not be so deep. So those are non-pathological Q waves. And then what are the pathological Q waves? The pathological Q waves are much deeper, and then they're much wider, deeper than 2 millimeters, meaning that 2 small boxes, they're deeper than, or 2 small boxes equal to or deeper than 2 small boxes. And the width will be more than 1 small box. That's where you begin to think about, is this Q wave pathological? Or if your Q wave is more than 25% of the amplitude of your subsequent R. And what does that mean? If I have this Q wave now, and this Q wave looks like a normal one, it's just a tiny, small Q. It's not very deep and it's not very wide, right? So then so same with the one here. So, but in LVH, sometimes the septal depolarization obviously would take a longer time because of the thickness of the wall, and you can have a Q that is looking like it's higher than or deeper than 2 small boxes. And I'm trying to find a normal ECG that would show. Sorry, okay, so let's look at this. You can see the Q waves here in leads 2. It's just a tiny Q, and all the Q wave here is not deep and it's not wide. So this more like just a non-pathological Q wave. But let's assume that this Q wave that you had here was very deep. And if you calculated the number of boxes, let's say the number of boxes are about 3 or 4, and then you calculate the number of boxes for the QRS complex and it's 10. So if I take my 3 or 4 boxes here, which is my Q wave, and I found the percentage amongst for the R wave, which is 10 millimeters, then it will be giving me about 30 to 40%. That means my Q wave is about 30 to 40% of my R wave, which makes it a pathological Q wave because it's even already taking more than 1/4 of the R wave. So that's what I was trying to explain with that. Okay, let's look at this one. So this Q wave is one box, about 2 boxes here. And then if I want to look at my R wave, I'll say 1, 2, 3, 4, 5, 6. So this is my Q wave 2. If I had to find a percentage, 2 out of 6, that's about 30 something now. That's about 30% or so. 2 over 6 would yeah, that's about 30%. So these my Q waves would seem to be pathological because it's occupying at least 2 boxes deep. Wide is not as wide as one small box, but then it's up to 25% of the QRS complex. It's actually more than. So that's what I was explaining about the Q wave. And then left ventricular hypertrophy, which is the common one that we like to, at least if you don't know anything about ECG, then you should know about left ventricular hypertrophy. You have the voltage criteria in left ventricular hypertrophy, and you have the non-voltage criteria. So the voltage criteria is that you are either counting something or adding something up to get your left ventricular hypertrophy. So the most common criteria, which is the Sophia-Lyons criteria, which developed many, many years ago, is when you add your impulse in V1, the S in your V1 and your R in your V5 or V6, and it's more than 35. So this is it. Let's assume you have an ECG, and then we'll soon finish. And you have your S wave in V1. So this is your S wave in the V1. If I had to add the boxes together, I'm like 1, 2, 3, 3. Okay, that 3 is 15. That's 3 is 15 small boxes. And I added it to the 4 that is left here. So I have 19 for V1. So the S wave in V1 is 19 millimeters. And I go to my V5 or V6, and I add the R wave in V5 or V6, which is 1, 2, 3, 4. That's 20 already. 20 plus, let's say about 1, 21. So 21 plus 19 here gives me 40. So if I add my S wave in the V1 and my R wave in the V5 or V6, and it's giving me something that is more than 35 millimeters, then I can say I likely might be having a left ventricular hypertrophy. That is one criteria. S wave in V1, R wave in V5, or V6 more than 35. Another criteria is just looking at your AVR and saying, is my R wave in AVR, is it more than 11? So if your R wave in AVR is more than 11, that's also suggestive of left ventricular hypertrophy. So I'm just looking at, okay, this one does not have the regular, and then we'll look at an ECG and then another criteria that we can use. So this is a voltage criteria, the Sophia-Lyons, which you're adding the S wave in V1 and R wave in V5 or V6. Another voltage criteria is this AVL, mid AVL, R wave in AVL more than 11. Another voltage criteria is this your Cornell's criteria. In your Cornell's criteria, I need to get an ECG. Yeah. So in your Cornell's criteria, you are adding your S wave in leads. Where's my V3 here? Here. Okay, here. So we are adding S wave in lead V3. Unfortunately, this lead does not have an S wave. So you're adding your S wave in lead V3 and your R wave in AVL. That's what you're adding. So let me just take it back. So the Cornell criteria adds the R wave in AVL. So that's your positive deflection in AVL and your S wave in leads V3. So if you add what you have here and what you have here, if the value is more than 20 in women or more than 28 in men, then that tells you you have a possible left ventricular hypertrophy also. That's another voltage criteria. You can see that we're adding things together or calculating the height of the electrical impulse. Or if you also have leads 1 and 3, if I add my R wave in leads 1 and my S wave in leads 3, and it's more than 25, then that's also a voltage criteria. So you can see that R wave in lead 1 and S wave in lead 3, if it's more than 25 millimeters, that's also a voltage criteria. Or any R or any S on the chest lead that is more than 30. So if I look at from V1 to V6, and my R wave, just without adding anything, is up to 30 millimeters. That's small boxes are up to 30. Or my S wave, the deeper one in V1 and V2, is up to 30 millimeters. If I have any of that without adding anything together, it's also a left ventricular hypertrophy. So there are a lot of voltage criteria. And so that's what a voltage criteria is. However, you have the non-voltage criteria. Non-voltage criteria means that you're not using the height of your R or your S to determine left ventricular hypertrophy. You're looking at other things. So if I look at my ECG now, I have a left axis deviation. I've looked at my P wave. I have left atrial enlargement. I've looked at the T wave, and there's T wave inversion in some leads, whether in the inferior leads or the lateral leads. If I put all those things together, without the height of my R or my S, then I likely have a possible left ventricular hypertrophy. And how do you want to look at this? That's the non-voltage criteria. Okay, that's the Romit-Hill criteria, where you use points to give your whatever. So let's assume that I have a left atrial enlargement, I have a left axis deviation. Once I have 5 points or more, then definitely I have an LVH. So if I look at an ECG and there's left axis deviation, there's left atrial enlargement, I can say, yes, there's a probable LVH on this ECG, even if your Sokolov-Lyons criteria is telling you is 25 mm. Or I have a strain, STT strain pattern. What does this mean? That means I have a T wave inversion, or I have a flat T wave or abnormal T wave pattern in any of the leads. Is also a strong point that you might have a left ventricular hypertrophy. So that's the non-voltage criteria. You can add it up with the voltage, but you can even use that alone to determine. So what does strain pattern mean? Because you see some ECGs and they'll say LVH with strain pattern or just a strain pattern. It means that the ST segment might be depressed. You can have a T wave inversion, and this is mostly seen in the lateral leads. It's 1 AV, LV5, and V6. So if you have this strain pattern, it actually buffers, it gives you a higher sensitivity for your ECG that this is LVH. Because ECG can be sensitive, but it's not very specific. Thin-chested people can have very high electrical impulses, and when you really do their echo, there's nothing there. So ECG is not all very specific. It might have a high sensitivity, but it's not very specific to tell you that, oh yeah, I've seen this ECG, there's LVH, and then there must be LVH. But when you see an ECG with an LVH with a strain pattern, meaning that there's the criteria for LVH there, and then there's T wave inversion, there's in this particular lead, then it gives you a stronger sensitivity for your left ventricular hypertrophy. How do you diagnose right ventricular hypertrophy? Using diagnostic criteria, if you have a right axis deviation, that tells you there might be a right ventricular hypertrophy. If you have a dominant R wave, so this is a normal ECG, we have said this so many times that the V1 and V2 are majorly negative, majorly an S wave that are found here because they are right-sided leads, and the leads on the ECG mostly shows what's happening on the left side. So, but by the time you start to see a big R in your V1 and V2, you can see the R here is even almost overshadowing the S wave that is here. Then it tells you that whatever is happening on the right side has taken over the whatever. It's now most likely the right side is even much more bigger than the left side now, because you can see the right side has more. So that's when you start to see a positive R in your V1 and V2. So that tells you that there's a left ventricular hypertrophy. But when you also now calculate the height of the R wave, you see that it's more than 7 millimeters tall. This one is much more than 7. This is about 14. So you see that more than 7 millimeters tall. Or if you see the ratio of your R to your S in this V1, if it's more than 1, what that means is that the R wave is even now taller than the S wave that you have here, then that also still tells you that you likely have a right ventricular hypertrophy, or if you have a right axis deviation, which is what is here. You can see you have a predominant S wave here, and AVF, you have a predominant R wave, and that is a right axis. So all that tells you that you might likely have right axis deviation. Now your ST segment. ST segment is meant to be flat and isoelectric. Yeah, so if you have an ST segment depression, then you'll be talking about whether you have an ischemia or you actually have an infarction, a non-ST segment elevation myocardial infarction. So ST segment should not be up to 1 millimeters in depression or elevation. So anything higher than 1 millimeters or lower than it is either you have an elevation or a depression. And where do you calculate this elevation or depression from? It's from the J point, which I would show you. So this is the ST segment. You can see the ST segment is the end of the S wave and then the beginning of the T. And it's meant to be isoelectric, meaning like it's just flat. And so if you have this ST segment being depressed, then you say you have an ST segment depression. If you have it being higher than the isoelectric line, this is the isoelectric line, it continues like this. So if you have it higher than the isoelectric line, then you say you have an ST segment elevation. And you look at the elevation or depression from the J point, which is the junction of this S and where the T starts from. That's where they call the J point on the ECG. And so let's look at this ECG now. This is the isoelectric line, and we can see that this is the S wave. So the S wave should ideally be ending here, but you can see that from the isoelectric line, the ST segment is much higher than the isoelectric line. So you have an ST elevation where you have an ST elevation in V2 here, and you have ST elevation also in V3, and then you also have an ST elevation in V4 and also in V1. So if I had to look at this ECG, I'll say there's an ST elevation in V1 to V4, and that tells you there might be like an anterior myocardial infarction because of the elevation of the ST segment. And it's important to know that you have different patterns of ST elevation. Your ST elevation can be convex or concave. So that's what we're going to know. You can have a convex or concave ST segment elevation. So this is an ST elevation in leads 1, in leads AVL, in leads V5, and in leads V6. And this type pattern of ST elevation is what? Is convex. You can see that the ST elevation here is convex. It's convex. And how do I know convex is for myocardial infarction? I just use the code. I say if something is vexing, it has to be very serious. So convex ST elevation is for myocardial infarction. The concave one, which is not so very bad and all of that, is for pericarditis. So that's how to differentiate, because in the pericarditis also you have an ST elevation, but it will be concave. Why for the one in myocardial infarction, you have a convex ST elevation. I don't believe that I didn't put a picture for that. So, but this is convex, but for the other one that is concave, you see that it comes down and then kind of slopes upward. It's on a different direction. It won't be looking like it's coming up like this. It will first come down and then you have something curved up. I'll should have put a picture. You can look that up. Then we'll go to the T wave. A normal T wave is meant to be asymmetrical, first half having a gradual slope than the second. Should be 1/8 or at least 1/8, but less than 2/3 of the amplitude of the R. So that means it shouldn't be high at all. It should be just small. And then, so an abnormal T wave can either be symmetrical, tall, peaked, biphasic, or inverted. So that you can have different T wave pattern. You can have a T wave that is just a flat T wave. So these are the normal T wave. You can see that it can just be not so high like that, beautifully curved and just nicely represented, less than at least 2/3 of the R wave amplitude. So if you have a flat T wave, if you have an inverted T wave will normally be inverted in AVR because everything in AVR looks down, which because of the position of the lead. So we should not be saying, oh, there's T-wave inversion in AVR, meaning that it's a right no. And if you look at the lead here, which is the AVL, you can see that the T-wave basically here looks like it's flat. So T-wave, when it's flat or when it's inverted or when it's biphasic, can mean that there's a form of myocardial ischemia. So that's why they call it T-wave changes, not it necessarily has to be T-wave inversion for it to be abnormal. Then you have the U wave. Most times you don't see the U wave on the ECG. The U wave, they said, really denotes Purkinje fibers depolarization, or some people call it the after depolarization. And most times you see it maybe when there's marked bradycardia, but most times you do not see U waves on the ECG. It's more prominent at very slow heart rate. And then, so like this is also one thing that you have to learn, the leads and what they look at. So if you have the lateral leads are leads 1, AVL, V5, and V6. Inferior leads are leads 2, 3, and AVF. The septal leads V1 and V2. Anterior leads V3 and V4. But if you have like ST segment elevation in V1 to V4, you just say you have an anterior myocardial infarction, not anterior septal. Most times you don't say that. And then AVR. So basically the anatomic groups, you have to learn them. You have to have them in your head so that once I'm looking at an abnormality in V2, I look at 3 and I look at AVF and actually I have same thing going on there. And that's why they say if you have an ST segment elevation in a lead, you must have it in 2 contiguous leads. So I can't just see an ST segment elevation in lead 1 and then I'm not seeing anything in AVL. I'm not seeing anything in V5 and V6. And I'll say, oh, yes, I have a lateral myocardial infarction. No, it's not possible that something is happening just in one and it's not even happening in any of the other leads. So that's why they say at least in 2 contiguous leads. So if I see it in here and I see it here, then yes, it's telling me a story. Or if I see an ST elevation in lead 3 and AVF, even if it's not very marked in lead 2, but then, yes, I have it in 2 contiguous leads looking at the same part of the heart. So, like we said, we cannot discuss the whole of ECG in one day. So we'll be rounding up now. And this axis, like we have learned, is what? This is a right axis. And then, who can tell us this diagnosis? And then we'll know that we've learned something today. Anybody?
It could be a left bundle branch block.
Oh, yes. So that's a left bundle branch block. Looking at the M pattern in this V5, and then this widened QRS with T-wave inversion here. And also the very deep S wave in V2. You can see the S wave in these leads, V1 and V2, they're very deep. So that tells you it's a left bundle branch block. Oh, finally. So thank you for your attention. I hope I have not bored you so much.
Thank you, ma'am.
Thank you so much, ma. Thank you, ma.
Thank you, Dr. Bumi Ajola.
Thank
This session
you,
has
ma'am.
thank you very much. This session has indeed been enlightening. I think we have all gotten the basics of what ECG interpretation is all about, from history to heart rate, axis determination, and the favorite, the Sokoleron's criteria for left ventricular hypertrophy. So before we go to the question and answering section, I want to let you know that the attendance link has been shared via the chat box, so you can click on it and fill the attendance. If you want to ask a question, you can raise your hands or send it via the chat box. We're going to read it out.
Sir, we are not able to on the attendance link.
Good evening, ma. Can I go ahead with my question?
Yes, please.
Okay.
Hello, sorry, please. There
Ma,
will be a
if
moderator for the questions that will be choosing who will be asking questions, please. And also for those on YouTube, please, you can write your questions on the chat and it will be read out. Thank you. Please, if you have a question, just raise up your hand and someone is going to call you to ask a question.
Hello, thank you very much for the lecture. We will appreciate if this slide will be shared for revision so that we can go over them. Then, can you kindly go over the LVH criteria, the Cornell's criteria? Thank you.
Okay, so I want to. So the Cornell's criteria, like I said, is a summation of, I'm trying to, I don't know why my screen is not sharing, but when you add the S wave in leads V3 and your R wave in lead AVL together, or for males, if it's more than 28, and then for females, if it's more than 20, then it will be best. I don't know. Can you see my screen? I can't see anything.
No, Ma, we cannot see it.
Let me stop it and reshare. Let me see. Okay. Okay. So let's look at one of the normal leads here, and to determine, we just get a good ECG. So let's assume we're using an ECG to try and determine, the Cornell's criteria. And I was using, let me use this one now. So you can see the V3. In leads V3, the S wave is quite deep. So if I had to count the amplitude in leads V3, it will be 1, 2, 3, 4. I usually count the big boxes first, then I add the extra. 1, 2, 3, 4. 1, 2, 3, 4 is about 20. Then I add the extra here is about 4, and the extra top here is about 3. So that's 27. And then I add it to the amplitude of the R wave. The R wave here is not so big, it's just about 2. So 27 plus 2 is 29 millimeters. So that would qualify for LVH in both males and females using the Cornell's criteria, both males and females, because it's more than 20, is more than 28. So that's the Cornell's criteria. You add your S wave in V3 to your R wave in AVL. Note, if you don't have any S wave in V3, then there's nothing to add, because you can have an ECG like this one, that the S wave is just, let's see, maybe just about 4. 4 plus what we have here, 4 plus about 10 is 14. So that is not LVH using the Cornell's criteria. So that's the Cornell's criteria for you. So any other question? I hope you got that though.
Yes, very much so. Thank you.
All right.
Thank you very much, Ma. Please, we are going to be taking all the questions once now, then so we can let
All right. Okay,
the
that's
teacher
better.
just answer all the questions or sort it out, because some questions might be intertwined. So, Dr. Choma Ude, we are going to be taking the first question. Then Sewanu Kotun, the next question. That's number 2. Adegboye Barakat, that's the third. That's the third question. Then I'm going to be reading, after those three persons, I'm going to be reading out the other questions on the chat box from both YouTube and Zoom. So, Choma, please, your question. Thank you.
Okay, thank you so much. Thank you, Ma, for the lecture. My question is about the potential difference in the leads. I didn't really get the concept of how the arrangements causes the potential difference. If you could go over it again.
Okay, it's just something that it's already like that. I'll just go over the.
Ma, thank you, Ma. Ma, please, Ma, can I just take all the questions, Ma?
Okay, all right.
Thank you, Ma.
That's
So,
fine.
please, number two, your question, Ma. So, the first question is about the potential lead difference. Number two, please, your question.
Okay, Ma. Good evening, Ma. Good evening, everyone. Thank you for the lovely session. My question is: in the case of old myocardial infarctions, do they usually the ECG pattern does it usually override the bundle branch blocks? And is there a time where there are patterns that overlay each other, or they look similar to each other, so it looks hard to tell, such that you have to now do an echo to find out?
Heard the question well, because I didn't get that. You said an old myocardial.
Okay, Ma.
Yeah.
Yes, Ma. I said that. Are there the one of my questions? ECG patterns that overlay each other.
Hello,
Can you
Sewanu,
type
your phone, please, can you type your question, Sewanu, please?
Yeah, your network is
Your
going
network
in.
is breaking. Thank you. Then, and Adegboye Baraka, that's the third person. Your question, please.
Good evening, Ma. Thank you very much, Ma. My question is about the non-sinus reading. If I want to calculate the heart rate, am I going to use the reading strip directly, count the number of R waves, then multiply by 6? Then my second question is to count for when you want to calculate the left ventricular hypertrophy, to count the S in V1 or the R in V5, V6, do I start counting from the isoelectric line to count the number of small boxes that will eventually add together? Thank you, Ma.
Okay.
Again, thank you for your question, Ma. I don't know if you got the question, Ma.
I did.
Okay, Ma. Thank you, Ma. Then also, for the question, someone was trying to ask, she said, are there times that different ECG patterns overlap, such that one has to do an echo to make the final differentiation? She was trying to use the myocardial infarction as an insight towards her question. Then the other question, okay, I think this is similar. Someone asked, how do we determine the sinus rating? Then you have already gone over the connect criteria. And then on YouTube, someone asked if you can go over the Sokolo-Lyon criteria. Then the last question, someone also asked, does it mean that without an S wave, we cannot use the Connect criteria? But I don't know if you want me to go over the questions again, Ma.
Yeah, just briefly. Yeah.
Okay, thank you, Ma. So someone asked, without an S wave, if it's possible to, okay, let me face it right. Does
Okay,
it mean that?
I got that. Without
Okay,
an
Ma.
S wave. Yeah,
Okay.
for the corneal
Then someone
criteria.
also said, can you go over the Sokolo-Lyon criteria again?
Yeah.
Then the other question is, are there times that different ECG patterns overlap, thereby necessitating need for an echo for a final differentiation? I think that's all the questions, Ma. Thank you very much, Ma.
Okay, that's very, very good question. So for the potential difference, I've just put this first here. I hope you can see the slide. So what is just trying to tell you about these leads, the link leads, they're just extra information actually, is that what lead 1 does is that it's a bipolar lead, lead 1, 2, 3. They're bipolar leads, and generally, not even for ECG, what do bipolar leads do? They determine the potential difference between one point to the other. So lead 1 determines the potential difference between the right arm and the left arm after you have placed your ECG electrodes. Lead 2 determines the potential difference between the right arm and the left leg And then the lead 3 also does that for the left arm and left leg. And that's where you have this triangle, this atrial triangle. And all these things are all the things that the scientists and chemists and physiologists and physicists have come together and used to be able to come up with an ECG and make sense out of it. So these are more like the intricate physics thing that have gone into determining and bringing out an electrical impulse from the body using these leads. So that's what it is. The augmented leads are unipolar leads, and those ones determine potential difference from one area and between the two other areas. It's just a bit more advanced than the bipolar leads, but all these things are not questions that will be asked to you, but just for information and telling you how they came about it. That's one. For the sinus rhythm and saying, okay, if you have what makes a sinus rhythm, if that's a question. Like I told you initially, to determine that an ECG is a sinus rhythm, it must have 4 qualities. And the 4 qualities are what? There must be a P wave before each QRS complex. There must be a P wave before each QRS complex. So let's look at the sinus rhythm strip. There's a P wave before each QRS complex. Then the RR interval or the PP interval must be equal in all the impulses you're seeing on the rhythm strip. RR intervals, PP intervals must be equal. Then the P wave must be positive in lead 2. Like I said, the P waves are also always positive in lead 2 and lead 1. So the P wave must be positive. If the P wave is not positive, if it's a negative P wave you have in lead 2, then the sinus node is not what is giving off that impulse. It might be another part of the atrium. So you might have an atrial impulse being given off. So that's not a sinus rhythm because it's not coming from the SA node. So the P wave must be positive in lead 2. And lastly, the rate must be between 60 and 100. Those 4 qualities are what qualifies you to say you have a sinus rhythm. Then somebody also asked about if you could use the rhythm strip when you have a sinus rhythm to calculate the rate. Sincerely, is an easy way out. The big boxes, small boxes are to be used if you have regular rhythms. However, even if you have a regular rhythm and you want to be lazy and you want to just have an idea of what your heart rate is, you come to the rhythm strip, calculate the number of hours you have there and multiply it by 6. And you get an estimate or at least something close to what you're reading. So you can also use it to, even when you have a regular reading. It doesn't mean that you have to have an irregular reading for you to use the 10-second rule. And then determining whether LVH has to be calculated from the isoelectric line. Yes, that's very correct. So if I want to determine my S wave now in V1 or my R wave in V5 or V6, I have to have where I'm taking the S wave or the R wave from. So if I'm taking it from here, so let's assume that
you can't see your screen.
Oh, you can't see it. That's
Yeah.
You can't see it, ma.
Oh, I don't know why it did that. Return back to meeting. Can you see it now? I think so.
Yes, we can see it now.
All right.
Yes.
Okay. All right. Sorry about that. So if you're using that, calculating your circumference now. So if I have to calculate, this is that isoelectric line is that straight line from where you have all those indentations of P wave, QRS coming from. So this is the isoelectric line. So if I had to calculate my R wave in V5 or V6 or S wave in V1, I will look for the highest R wave in V5 or V6. So it has to be that if I have this and I have this, I see that the one in V6 is higher. That's the one I'll choose. So I'll come here and say, I have 10 boxes here. That's from these 2 big boxes. I have additional 2 here. That makes it 12. And then I add it to what I have here, which is another 10. Looking at the isoelectric line, that's 22. So yes, it has to be from the isoelectric line. Then if you have different ECG pattern overlap, yes, sometimes ECG does not have 100% sensitivity or specificity. Sometimes you have an ECG and it's not tallying. Maybe you even have an ST elevation on your ECG that looks like, yes, an ST elevation or deep Q waves, persistent ST elevation. and you do your troponins and it's not high. Why are these ST whatever segments, why is it elevated? You could have an aneurysm, ventricular aneurysm, which has been there following an injury in the heart or maybe a cardiac disease and all of that. And we tend to know that this set of people will have ST elevation. So yes, sometimes you might have to do further investigation to unravel what exactly is going on. But definitely, like I said, ECG is reported in context to the person you're reporting the ECG, the age, the gender, and then the clinical context. Clinical context is very important. Not that you just report an ECG because you're seeing it. So then the Sokolov-Lyons criteria, I think I've gone over that one. So Lyons criteria, V1, you're using V1, V5, or V6, and you're adding your S wave to your R wave, either here or here, to determine if they're up to 25. And then without an S wave, can you do the Cornell's criteria? Really, no. But let's see, if like this one, there's an S wave in V3 and it's about 10, yeah, about 10, if I had to calculate 10 here. And then I come to the AVL, my AVL, the R wave here is about 7 in the highest one. So 10 plus 7 is 17. It doesn't, whatever, but let's determine that in V3, there was really it's not like there won't be any S wave, maybe it's just about 2, and then, or 1, or then you calculate 1, add it to 7 here, it really does not make sense. So it's not like, so even if you don't have anything, add 0 plus the AVL, but then that means you're not doing Cornell's criteria then, because you're not adding so it has to be that you have a significant, or you have somewhat an S wave in V3 and an R wave. Like sometimes you look at AVL and AVL is completely negative. That means you're not adding anything. You're adding maybe 7 to 0. Then that's not whatever. It automatically tells you you can't really use your Cornell's criteria then. So I think I've gone through all the questions. Hello?
Yes, ma. Thank you very much, ma. Thank you so much, ma. You have gone through all the questions. Hello, ma.
Yes, I can hear.
Hello, ma.
Yes, I can hear.
Yeah, thank you very much, ma. I want to really thank you very much, ma. I want to really appreciate you for this session. It's very difficult starting such a program because you really have to lay the foundation for us to be able to continue. I think everyone here is inspired, and maybe after this session they do their rough work, they are going to be getting towards the next session. So we really appreciate you for starting such a great foundation for us on this training, and I know everyone here that was actually involved and participated is really happy. Thank you very much, ma. Ma, please, okay, ma, no problem. We will ask you something later on your privately. So thank you
All
very
right.
much now for the session. Thank you very much for everyone that joined us today. Tomorrow is another day, same time, 4 p.m. And as usual, we'll try our best to keep to time. All the best. Do your small extra practice, and we wish you all well. Thank you very much. Good day,
All
everyone.
right. Thanks for listening. I hope you picked 1 or 2 things. All
Very
right.
much.
All right. Bye.
Thank you, ma. Bye.
Thank you, ma'am. Thank you, everyone.
Thank you,
Thank
ma.
you,
Thank you
ma.
so
Thank
much,
you,
ma.
ma. Thank you, ma.
Thank you,
Thank you,
ma.
ma.
Thank
Really
you, ma.
appreciate
God
it,
bless you,
ma.
ma.
God bless
Yeah.
you, ma.
Thank you, everyone.
Thank you, ma.
Thank you so much, ma.
Yeah. Thank you. You'll get the slides. I'll share it with
Ma.
the
Thank you, ma.
Thank you, ma, for the class.
We appreciate you, ma.
I appreciate you, but
You're welcome.
Thank you.
Got a decent goal scoring record against Chelsea. He's exploited the Blues back line again. Is this the